When you're in the OR, resecting a sarcoma, getting a clean margin, well, that's everything, isn't it? It's the single biggest factor that determines your patient's outcome. But what if you could make the tumor itself glow? What if you had a real-time map right there in front of you, guiding your every cut? Today, we're going to dive into a technique that promises to do exactly that.
All right, here's a quick look at our game plan. We'll start with the problem itself, those tricky sarcoma margins. Then we'll get into the technology, ICG fluorescence. Look at a study that put it to the test, and unpack the pretty amazing results. We'll also walk through what it actually looks like in the operating room, and finally, talk about what this all means for the future.
So let's start with a challenge that every single one of us who treats sarcoma is all too familiar with. We're talking about the critical importance of that resection margin, and the very real consequences when you find out after the fact that microscopic disease was left behind.
25%. Just let that number sink in for a moment. In the study we're about to break down, this was the rate of unexpected positive margins for patients who had conventional surgery. Think about that. That's 1 out of every 4 cases where the surgeon was confident they got it all, only to get that dreaded call from pathology saying otherwise.
And let's be crystal clear, this isn't just a technical problem that means another trip to the OR. An unexpected positive margin has a direct and serious impact. It's tied to a much higher chance that the tumor will come back right where it started. And even more sobering, it's linked to a decrease in the patient's overall survival. The stakes just couldn't be higher.
So, the big question is, how can we possibly get that 25% number down? Well, the answer might just come from a simple, incredibly safe dye that allows us to see what our eyes can't. It's all about making the invisible visible.
Let me introduce you to Indocyanine green, or ICG. Now, this isn't some new experimental compound. It's a fluorescent dye with a fantastic safety profile that's been around for decades. The magic happens when you give it intravenously. It has a knack for accumulating in sarcoma tissue. Then, when you're in the OR, you just flip on a near-infrared camera and boom, the tumor tissue glows, giving you a live intraoperative guide.
So you're probably wondering, why does it pool in the tumor? Well, it mainly comes down to something called the enhanced permeability and retention effect, the EPR effect. Just think of it like this. The blood vessels feeding a sarcoma are kind of leaky, which lets the ICG dye seep into the tumor. And on top of that, the tumor's lymphatic drainage is terrible, so the dye gets trapped in there. The end result? You get a much higher concentration of this glowing dye right where you need it, and not so much in the surrounding healthy tissue.
Okay, the theory sounds great, right? But the real question is, does it actually work in practice? Let's turn to the evidence. We're going to dig into an extended case series from 2021 that put ICG-guided surgery head-to-head with the conventional approach. So here's how they set it up. The researchers looked at 115 patients, all with high-grade sarcomas. They created 2 groups. The first group, 76 patients, had the standard of care surgery, no fluorescence guidance. The second group of 39 patients, they were given ICG before their operation, and their surgeons used that near-infrared camera to guide the resection. And this is where the story gets really compelling. Let's take a look at what actually happened to that positive margin rate when surgeons had this fluorescent roadmap to help them.
Okay, let's just break this table down, because the numbers speak for themselves. In the conventional group, 76 patients, 19 of them had an unexpected positive margin. And yep, that's our 25% rate. Now, look over at the ICG-guided group. Out of 39 patients, only 2 had an unexpected positive margin. The difference is just, well, it's stark.
And here's that same data in a bar chart, which really drives the point home. The rate of unexpected positive margins absolutely plummeted from 25% all the way down to 5.1% in the ICG group. We're talking about a 5-fold reduction. That's a statistically significant result that is pretty hard to ignore.
So those results are obviously pretty exciting, but I know the question on every surgeon's mind is a practical one. Okay, that's great, but how does this actually work in my OR? What's the workflow like? Is it complicated?
Well, the protocol from the study is actually quite straightforward. The dose is simple, 1 milligram per kilogram of ICG, given IV. Now, the most critical part, the real key to success here, is the timing. You give the dose 16 to 24 hours before surgery. This gives the dye time to clear out of the healthy tissues. Then, during the operation, you use the NIR camera not just to guide your dissection, but, and this is huge, to inspect the wound bed for any residual glowing spots after you've taken the specimen out.
This slide is so important because it shows you exactly why that 16 to 24-hour window is non-negotiable. Here, the ICG was given right at the induction of anesthesia, too close to surgery. Now look at the image on the right under the NIR camera. See how everything is glowing? The tumor, yeah, but also all the surrounding healthy fat. This background noise just muddies the waters and makes it really tough to see your true margin.
Now contrast that with this. This is what it looks like when you get the timing right. This patient got their ICG dose the day before their operation. Look at the image on the right. It's like night and day, isn't it? The tumor is lit up like a Christmas tree, and the surrounding healthy tissue is dark. That incredible contrast is what gives you a crystal clear target for your resection.
So the potential here is obviously enormous, but with any exciting new result, it's really important to take a step back, look at this critically, and talk about where we need to go from here.
We have to be upfront about the study's limitations. It was retrospective, and it wasn't randomized. So to really prove these results, and potentially change the standard of care, the next step is clear. We need a large, prospective, multi-center randomized controlled trial. That's the gold standard. At the same time, you can bet the technology itself will keep getting better, maybe with sarcoma-specific dyes, or even AI helping to analyze the images.
So what's the bottom line here? Look, a 5-fold reduction in unexpected positive margins, that's a signal you just can't ignore. And while, yes, more definitive research is absolutely needed, this technique really forces every single one of us who treat sarcoma to ask a pretty profound question. Are we looking at the first real step toward a new standard of care?